Welcome back to Citizen Extra. Many thanks indeed for staying tuned. As I mentioned just before the break, a new Ministry of Health report has laid bare the sorry state of healthcare for pregnant mothers in the country. To put all this into perspective, let's now listen to a report by Wilkista Nyabwa.
In Kenya, every year, 6,000 to 8,000 women lose their lives while giving birth, a dizzying number that is more than a statistic for those who have lost loved ones. The bond between a father and his children manifests as his family watches a football match, their bond perhaps stronger than most. Dan Shikanda raised his 3 children all alone after his wife died while giving birth to their 4th child 12 years ago. A faraway look comes into Dan's eyes as he recalls the events that led to his wife's death, the joy when he received the call telling him she was in labor.
Jumped into the car, went all the way joking. I was telling her, hey, make sure you don't deliver in the car.
The anticipation when they arrived at the hospital and she was wheeled to the delivery room, and then the panic and helplessness when complications set in.
She said, I have lost breath. And that is the time all of us realized the contractions had gone.
Dan claims things went wrong when healthcare workers wrongly administered a drug to hasten labor. His wife started to bleed. She died soon after. The child, who was delivered through a C-section, also died 3 weeks later, leaving him with a hospital bill of 8 million shillings, 3 children to raise, and bitter memories of the traumatic incident. So over a decade later, when he found love again, he and his new wife chose to have their 2nd child in America.
The gynecologist was very patient. The nurses around us were very patient. In fact, they used the same drug. The difference is that the drug, the rate at which they were giving the drug was so minimal.
These are some of the stories which emerged when the Ministry of Health set out to probe maternal deaths in the country. The ministry found that 945 maternal deaths were reported in 2014. The real number, experts, however, believe is much higher, attributing the low numbers reported to poor record keeping. The confidential inquiry into maternal deaths found that the median age of women who died was 27. Most died while having their 1st or 2nd pregnancy. Tellingly, the inquiry revealed that 9 out of 10 maternal deaths had been caused by substandard care in health facilities.
It's about delays in treatment, it's about poor treatment, it's about health worker not being available.
More than 80% of the mothers somehow received suboptimal care, and that which could have impacted on the outcome.
The main causes of death were obstetric hemorrhage, where 2 out of 5 women died from losing too much blood. Direct causes such as hypertension and diseases such as HIV and anemia. It emerged that 15 counties, among them Marsabit, Mandera, Garissa, Lamu, Migori, Bungoma and Nairobi, had the highest incidence of maternal deaths. The challenge: to scale up support to caregivers in even the most remote areas. County governments were also urged to allocate more resources to healthcare in order to enhance access to quality healthcare services. Today, Shikanda is a father of 6. Starting afresh has given him a new lease of life, one he hopes other new parents will also be able to enjoy as maternal deaths drop.
Very, quite a revealing report there. The report reveals that between 6,000 to 8,000 women lose their lives in childbirth every year. We want to find out from you at home why you think this happens. Let's get your view. 22422 is our SMS line, and talk to us on our social media platforms as well. The hashtag is Citizen Extra, and I'll try and read a bit of your feedback later on. Let me introduce my guest in studio now, one of whom you've watched share his story. Very brave of him to do so. Dr. Dan Shikanda, a consultant. He wears many hats. But today he's here to share about that particular story and give us more details as he feels led to do so. We also have right next to him Dr. Wangui Muthigani, a program manager, Reproductive and Maternal Health Services, Ministry of Health. Karibu sana daktari.
Thank you.
And right here next to me, my colleague, so to speak, Joy Wanja Muraya, a medical journalist. Also, thank you for finding time to be here with us.
Thank you so much.
I want to ask you the same question that I've asked our viewers today. 6,000 to 8,000 women, and I'll start with you, Joy, lose their lives while giving birth annually. Now, yesterday as I was doing research for this interview, I asked a few people their thoughts on that particular statistic, and one of them reacted is that data for 2017, 2018. How come this is still happening in this country today? They were actually quite shocked, and I had to literally show them the report for them to understand. Let me get your reaction, your thoughts on the kind of numbers that came out of that particular report.
As a journalist, let me say first of all that this is a very bold report, coming from the Ministry of Health and accepting that, you know, this is a situation. This is the standards of care that we have for maternal and maternal health in Kenya. I think it's from this point that we need to start addressing the issues of why are women dying. And because the report also says where are they dying and when are they dying, this is from this point that we need to discuss how this needs to be addressed. And it's an all-inclusive approach. So right from myself as a journalist to the community level, the county level, the national, private and public sector, it's a report that we need to own, and from then on say mothers should not die when giving life.
Okay.
Yes.
And for our viewers who might be wondering, I wish they could know more about the report. We'll continue putting up some of the slides, and actually some are up there right now for you. Dr. Wangui, let me come to you. What prompted the Ministry of Health, and if you can give us the thinking behind it, to release this report? Some would say the data can cause many to say that you're not doing a proper job, that you've slept on the job. What led to the release of this particular report, a confidential report for that matter?
So the reason we did this report, and as it's rightly named, is we are mandated to save mothers' lives. And we realize that we have to start from a point of where are we now? We can't do much if we're not sure where we are. So why not start by looking for the data, find out how many mothers are we losing, why are we losing them, then what actions can we take in order to save their lives. So it's laid bare by the Kenya Demographic Health Survey of 2014 that we are still losing about 6,000 women every year. This translates to about 20 women dying every day. By the end of today, we will have lost 20 women. And let's put it in perspective. This is a matatu having a fatal crash daily. But we don't have the voices of these women, of these families who are affected, speaking. So we took a bold step. We were like, let's take it upon ourselves to save our mothers' lives. And it might need to start from who have we lost? What can we learn from that? And then what actions can we take in order to save lives of women like me who are now pregnant and hoping to have healthy families.
It is in order to say congratulations, even as you carry on.
Thank you very much.
Just briefly, of course, I'm trying to help our viewers quickly understand this report because they may not have it in their hands.
Yes.
Some of the main causes highlighted when it comes to maternal mortality include obstetric hemorrhage, that's basically heavy bleeding.
Heavy bleeding, yes.
Hypertension and HIV/AIDS. Talk to us a bit about that before I come to Dr. Shikanda.
All right, so for a very long time, hemorrhage and we'll call it bleeding has been a problem for women for, let me say, from biblical times. When Rachel died as she was giving birth to Benjamin, that's in the first, that's in the yeah. So this has been a perennial problem. But there are things that we can do to change these outcomes. Heavy bleeding has been a problem for women in this country, about 40%. That's almost half of the women experience heavy bleeding, and of that, they're the ones who die the most. And there are many reasons, many health system reasons, many individual reasons that lead to that. Then there are conditions called hypertensive diseases in pregnancy. One very common one is preeclampsia. I'm sure we've had a lot of discussions about it sometime last year. A very popular member of our society passed away from preeclampsia, and it was highlighted quite broadly by the media. So preeclampsia is hypertension. You get high blood pressure in pregnancy, proteins in your urine, and it makes your body retain a lot of fluid, so it swells up, and you get very puffy hands, and sometimes it can cause internal bleeding, which leads to death during pregnancy or during labor. And then we have heard a lot about HIV contributing to maternal death, and this can be due to several reasons such as infections, anemia in pregnancy, that also somehow lead to both hemorrhage, the bleeding, and the hypertension in pregnancy.
Thank you for putting all that in perspective. Let me come to Dr. Shikanda. That story aired 2 days ago. I guess I'm curious to find out what sort of reaction did you get from your friends, society, and what sort of thoughts and new insights do you now have now that a lot more people know about what you went through?
Thanks, Waiga. In fact, when it aired, I was not at home. I was called by so many people, including even my in-laws. Of course, it brought back the memories, but I explained to them, I told them, one, when I saw the report, and I would like to congratulate the government and the ministry. So
you've actually had a chance to go through the report?
Yeah, I've gone through the report, and this is the beginning of solving this problem. I know so many people think it doesn't happen in Nairobi, it only happens in rural areas, in remote areas. No, it is happening even in the biggest hospitals we have in this country. And I'm happy somebody has woken up and done this report and put it on the table for people to know the problems which women are facing in this country, the problems that we are facing, which can be solved. And we save so many mothers. I'm not saying that once the report is tackled and all recommendations are put in place, we'll be saving all the mothers. No, we are losing mothers simply because of negligence. Like in my case, I can say it was sheer negligence, and if somebody just stopped for a minute and forgot what they were doing when they had actually been called, today my wife could have been alive. Today my baby could have been alive. So when the report came out, and I was part and parcel of people to react to it, a big load was removed from me. Because when my wife passed on during delivery, we tried to expose this thing, what is happening in a hospital, but it was not possible. All the avenues were like blocked, and it kept haunting me. It kept...
so somebody wanted to hide the truth.
Yeah, somebody was hiding the truth. How will we help her when she's going to deliver? The same thing might happen to her, but if we talk and our voices are heard, it will not happen to her, and it will not happen to my neighbor and the next person. So the reaction from so many people were, this thing happened. Even others had forgotten, and most of them who knew it thought she died maybe up country. She died in Nairobi, in one of the biggest hospitals in this country. And the infrastructure in that hospital is robust. Everything, skilled labor, everything is there.
And you told our reporter that things went wrong when healthcare workers wrongly administered a drug that was meant to hasten labor. To hasten labor, and I don't think the workers knew exactly that drug very well, because I've heard of, after it happened, I went through the drug, and I realized. You studied it. Yeah, I realized maybe our doctors do not read. Our doctors, our nurses do not actually go through what they're supposed to be giving before they give. And as I said, later on, we experienced the same scenario. I was in a labor ward, in a labor room with my second wife, and same drug. In a different country. In a different country, and the difference was amazing. Okay, my goodness. Joy, let me get your reaction to what Dr. Shikanda and, of course, Dr. Wangoi have had to say. I've seen you flipping through the report quite a bit. Share your thoughts with us.
Let me first say that, it's very bold for Dr. Shikanda to say it, to share his experience, and I believe in this case the media failed you. It's the one chance where the media, as a journalist, we should have come up and given you a platform, because the media should be an agent of change. Because with the kind of reaction that you've received from your story, it only needed to be told to somebody who, would take the story forward. Because one, the media is an agenda, sets the agenda in this country. In other countries, there has been, in other countries where the media have been used to, change the story of how maternal health is told, the media has become a partner. So, for example, in Malawi, what they did is that they ran a maternal health campaign on radio, in community radio, and they had listening groups. In Ghana, they had a similar program, and it was one way of convincing the men to actually accompany their partners, so that when they're going for care. I think that's what we need in Kenya. We need to move away from where we think that politics is our top story. As journalists, we also need to ensure that we tell stories of success. So I see a follow-up.
Not just doom and gloom.
Yes, it shouldn't bleed for it to lead. So it's an opportunity for the media to take up a story and run with it, because we live in the society as journalists. It is our role to amplify what is happening in the society.
So you actually feel that if media had been more proactive in covering cases of maternal mortality, that the 6,000 to 8,000 women that we lose every year, that number would have gone down, or at least it wouldn't be a surprise right now to know about those statistics?
I think maternal mortality and also the death of children and infants will be almost zero. Almost zero if everybody in the society plays their role. For the media, our role is that we have this privileged space. We have access to the doctors, we have access to the political class, we have access to the policy makers.
Exactly.
So our role is to take this information and put it across to the media, to the public, in ways that they would understand. So we have the newspapers, and that serves a particular group of people. We have community radios, we have television, we even have platforms where we're able to bring communities together. Through the media, then the public would be involved, so that if I'm a pregnant woman, then I would know these are the danger signs. If my wife is pregnant, or my brother, or if a brother knows, the sister is pregnant, then if through programs they're able to know these are the danger signs, it's at this point that I need to go to hospital. It also creates a form of ownership, where if the community knows this woman, she seems like, she's not in a good situation, then the community takes up the role and says, it's time you went to hospital. So as the media, we should take up the role. Let's bring the world together. We may not be experts, but we can bring the experts to share the information to the general public.
Okay, and I think you've actually gotten us on the right step, talking about the way forward. Now that the report is out, now that Kenyans know what data is in there, how do we ensure that next year at a time like this, we won't be talking about the same thing? And let me come back to you, Dr. Wangui. I tried to look at which countries in Africa are doing it right when it comes to maternal mortality and dealing with it. And one country that really stood out was Eritrea. They're one of the 4 African countries said to be on the track to achieve Millennium Development Goal 5 on maternal health. Yet one could say that poverty is also a reality there, as compared to here. As you do your research, as you study other countries in Africa, what are some of them doing right that Kenya needs to start thinking about implementing right away? You could say releasing data like this could be the first step, but let me preempt you on that. So why does Eritrea, for example, stand out? I know you might not have the exact details, but I'm sure you've read some of the studies.
So just to respond directly to your question on Eritrea, Ethiopia have very strong community health services. So they recognize that in order to reach everyone and leave no one behind, you must start from the community level. So that community level is homestead to homestead. So you ensure that you've mapped out every pregnant woman, every child, because this system isn't just about the mother. This mother got pregnant to get a healthy child and to have a healthy family. So they have a very robust community health system. And in this community health system, they use lay people who are of great repute in your community, who go out spreading key messages that promote health in order to improve antenatal care services in Eritrea and Ethiopia, in order to get more women receiving skilled birth attendance, and a follow-up system through the minute you get pregnant, or the minute you decide you want to get pregnant, all the way to the time when the child is 5 years old. Because those are the critical 1,000 days, the first 1,000 days of life. Now, Kenya,
what can we learn from that?
Kenya is very strong behind that, where we want to strengthen our community health systems. So we even have a department that deals only in the community health strategy for this country. So we're setting up systems, we're getting our partners together, and we're talking to our communities to see the importance of having a very strong community health system. But this cannot work alone. In Kenya, it's called level 1. That's the first level of your health system. Then we need to ensure that once we strengthen the basis, we can provide the best care at your dispensaries, at your health, your health facilities, in your big hospitals. So it's building up a system from ground up. Now, Kenya is not just looking at community health, the facilities. We looked at this report because we know where we can get quick wins.
Low-hanging fruits.
Yes. And those quick wins are in the health facility for the Ministry of Health. When we come to the community, we still have issues like child marriages. I mean, those contribute so much to maternal deaths. FGM contributes a lot to maternal deaths. Having HIV, poverty, all those still contribute a lot to these high numbers that we see. And that by the time a lot of women are getting to the facility, there's a lot that's been happening at home. Maybe you turned to your traditional birth attendant. Maybe you've been taking something to just speed up labor. And a lot of people are scared of hospitals. You've had Dr. Shikanda, and my heart really goes out to you. That is really a heart-wrenching story about your wife. And her death will not be in vain, because we will work to ensure such incidents.
If I can interrupt you on that note, you raised something very interesting about how people are, I think you were getting to that. You said, so a lot of patients come to the hospital already with a lot that's happened that you need to take into account when they get to the hospital.
By the time they get
two people
there.
have already texted to talk about nurses who handle women. They are complaining. I don't know if that's something you're getting. Let me read one quick SMS. Sarah from Eldred says, another concern is how nurses handle women while they want to deliver. I lost my first child due to negligence of nurses. I tried to tell them I was delivering that day. They kept looking at my small stomach and the way my body had swollen all over. Kindly, nurses, use your skills well. Another person here, but you say, Mudhoni from Kiambu, you go to a hospital at 3 a.m. unakuta nurse akona stress zake, anakutesa na kukuambia manene mpaka unaogopa kabisa kuzaa. I hope I have read it in the right manner, but I think you get the message.
I get the message.
You briefly respond to that.
And it comes out strongly in the report. We even talk about it and say, once you get to the health facility, now it's the onus of the health system to ensure that you have the best quality care according to our constitution. And this best quality of care is in two parts. There's the provision of care, like what you're talking about. The drugs, are there health workers on the ground? Do you have beds? Do you have equipment? That's the hardware of quality of care.
Software.
Then now the software is what she's pointing out to. That interpersonal relationships that we have. And that is harder than you think in terms of changing a system, because it's behavior change. We have a program already running. It's called Respectful Maternity Care. And it's talking to both the communities, the women, our nurses, our doctors, to be able to communicate, to see the humanity in everybody, and to give dignity. Because I feel that is what Mudhoni was talking about. That dignity that...
I'm trying not to interrupt you, but I wonder, when the nurses themselves are either overworked, underpaid, stretched beyond their resources, and maybe Joy, you can come in on this as well, because you probably studied this a lot more than I have. How can they be expected to turn into super human beings when they get to work? So I feel like it's almost a larger discussion than a motivational seminar with nurses in hospitals that be the best nurse you can be. I feel like there's a lot more, but you go ahead.
Should I go on? Because this is now my pet subject.
Okay. Briefly, so that I can bring in the others as well.
So it doesn't look just at the client side. This is a relational program, and it looks at both the healthcare workers, the communities, and how they interact within the health system. So just looking at even the issues that were brought out during the strike, we're overworked. We don't have infrastructure that's supporting us. And I'm speaking as both a doctor and a program manager. You come and meet that these nurses who took care of the patients in this report could have been only one person in the hospital. And you're probably handling 10 women in labor, and this one person gets a complication. You don't have a system that's supporting you. So of course by the time you come in and you look well, she's just going to tell you you're going to be abandoned. There are bigger issues on my plate, right? So the respectful maternity care is not to give somebody a jab in the arm and tell you go forth and be kind. It's critically looking at the system, getting the community to also come into the health facility before delivery, to see the infrastructure that's there, to interact with your nurses so that by the time you're coming to deliver, these are not strangers, and it gives them the chance to also be advocates for that health system. If you only have 1-2 nurses, you're not going to get the care you deserve. So it's bi-directional, and it's very progressive in terms of not only the niceties, but getting the whole system running. It's actually at the very center of improving the health system.
Let me bring in Dr. Shikanda to you've been keenly following every word she's saying. Just react to what she said as you contrast what you actually went through.
I think she's right when she talks about the software, because everything can be in place. Like in my case, everything was in place. The only thing which was not in place was the doctor's mind and the nurse's mind. Because clearly, as I remember, when we were in that labor ward, the doctor came in like, I have been doing my thing, I've been called, and I really want to finish and go back.
That's what you felt?
That's what I felt.
It was clear to you?
It was clear to me. The nurse was not also with us. The nurse was just there. And by the time they were actually drawing that drug into a syringe to give, they were not like communicating, because when the doctor came in and realized that things have gone haywire, he actually asked the nurse, did you give the drug? And the nurse was, yeah, I gave the drug. So which means, I don't know who made the decision of giving the drug at that particular moment, and when the decision was made, how was the drug going to be administered? Because clearly what I read from what the drug does and everything about the drug, I think the doctor must be known. So you see, we had gone through everything. We had gone through antenatal, everything. We went to the hospital talking, discussing, making jokes, laughing. At the end of the day, she left in a casket. So what was the problem? The infrastructure is intact. Skilled labor was intact. The hospital, we were in a hospital whereby even if she ruptures her uterus, she can actually be taken to theatre and be supported. And
you had access to the best facilities in that.
When she had ruptured and she told us, I'm dying, the doctor laughed. You cannot die. He actually laughed, literally laughed. You, Elizabeth, you cannot die. By the time they were supposed to rush her to theatre, they were busy removing rings, trying to remove earrings. It's me now shouted to them, we don't have time. If it's to save her, let's go. So clearly, the problem is not about infrastructure or what. I think what she's saying is right. The problem is right inside the hospital, where if we get the right mentality, if we have that behavioral change, so that when I come in as a doctor, I'm not just coming in to work and go home, and whatever happens, whether I lose a patient, it's just part of the statistics. Death is such a finality that if you lose your wife, your mother, your parent, she's gone. I spoke to her 2 minutes down the line. She kept quiet, and up to date, she has not spoken. But you see, the people who are handling her do not know that. They just thought this is one of the patients we have. Whether she makes it or she doesn't make it, life continues. I'll still be on salary, I'll still be on everything. When you try to take up with the hospitals, now is when you get the real
understanding of
understanding of what is happening, the health system. You will even be told things. You wonder whether you are talking to human beings or what. In fact, there's somebody who told me, do you think she's the first one to die? Or is she the last one to die?
You're actually quoting those are some of the exact words to you.
Somebody who works in a hospital, in the hospital. So, where do you go next?
Joy, where do we go next? I don't even know how to.
Let me say that it's unfortunate that we live in a very capital-driven society. And unfortunately, our doctors are, motivated. Most of them are motivated by the shilling. So as Dr. Shikanda says, we have infrastructure, we have everything in place, but I've gone into labor and I need my doctor, but they're running from the north of Nairobi, coming to the south to another hospital. It's very unfortunate that it's about how much money will I bring in at the end of the day. It's also unfortunate that that most of our emergency operations in maternal health, those are cesarean sections, are done on Friday. So why are they done on Fridays? They're done on Fridays because the doctor is able to schedule a CS section, and so that they can come and see you through until Sunday, then discharge you on Monday. Unfortunately, the weekdays don't give you that challenge. So the data shows that, and NHIF was on record saying, there's a very high rate of cesarean sections. I think for us, that's where the story is. Why is there such a high rate of cesarean sections? And these are those that are planned. I'm not talking about those that are emergencies. So we need to rethink how, as a society, are we the ones who are driving these doctors to actually be more capital-driven? Because they have, for there to be that need, there's a demand that's driving it. Why do we not have so many of these doctors, sitting and attending to their patients at public health hospitals, at referral hospitals? Why do we find very long queues in private hospitals and in clinics? So there's a particular gynecologist who you will report at 10 o'clock and you'll see them at 4 p.m. As a society, I think we need to to have a rights-based approach.
Okay.
We need accountability.
This is one discussion I see we'll clearly not finish in one sitting, but I want to get your final thoughts on this. And Joy, I want to start with you briefly.
Yeah.
There's a danger that we will focus on Nairobi and urban centers and forget about, I'm sure there are people watching and thinking, as you people have this discussion, some of us don't have access to half the things you're talking about. Last year, I think it was a couple of years back, you did a story about traditional midwives of Isiolo. You highlighted how women choose to use traditional midwives despite the fact that they can make their way to hospital. Talk to us about how using how that system has worked from your research. How does it affect the fight against maternal mortality? She says in Eritrea, somehow they found a way to make it work. I don't know if that's translatable here. Let me get your thoughts on that.
My story back in 2012 was looking at Turkana women in Isiolo who opted to give birth at home, despite the Isiolo district hospital then being less than 10 kilometers. So largely this was for cultural reasons, because women who give birth in hospitals are not respected within the community. They are weaker. So even with the hospital being there, the women did not deliver at the hospital. So there was a program where the hospital trained traditional birth attendants to deal with initial cases, just when delivery is about to happen. They empowered community health workers to do it. However, this model only works for areas that are limited in terms of accessing care. This has worked in Isiolo, and I think it can work in places where cultural issues are really a barrier to them accessing care. However, this kind of model should not replace care within a hospital setup. One other model that can work is empowering nurses. Training nurses in a way that they are able to actually do deliveries in places where you do not have specialists. This is in northern Kenya and in remote areas. So empowering nurses in a way that they can actually handle a delivery and progressively so is one of the ways we need to look at it. Finally, we need to have a body which looks at the welfare of the Ministry of Health.
Another body.
A body like a regulatory body. We don't have that, like a health commission currently. To bring together the training of specialists, and also, the everyday running of the hospitals at the county level. So the county cannot actually even train a specialist, probably takes around 10 years. Even a governor who's actually willing to train specialists, that is beyond their scope. So we need a body that brings these two sections together, because we cannot continue having mothers and children dying out of preventable causes.
Okay,
9 out of 10 deaths is just too much.
Yes, I'll have to interrupt you there to get a final thought from Dr. Wangoi and Dr. Shikanda briefly, please.
One thing is, we have to get leadership in the health system that promotes the health of Kenyans. So we really commend the free maternity services policy that the president came up with, the universal health coverage declaration for the next 5 years, and the advocacy work that the First Lady has done through the Beyond Zero campaign. Right now at the ministry level, we are looking into legislation for maternal, newborn and child health in order to secure some of the things that you're talking about, that oversight body that ensures we never ever see a report that has this kind of numbers again, and that we have progressive decline in maternal deaths. The other thing is homegrown solutions. So I like what you're talking about, the midwives, but we can make it bigger, give them skilled attendants, and have maternity shelters very close to the facilities, such that it's the community that comes up with these initiatives. And for our healthcare workers,
so that no one faces stigma if they use them. It's community driven.
Community driven, and it's designed by themselves. And then for the healthcare workers,
the last one, please.
Yes, this is the last one. Let's combine all those, the regulatory bodies, but also give them the motivational tools that they need to work, and a great accountability system. And all this we can do through that legislative piece called the MNCH bill that we're currently working on to improve lives of mothers and children.
Okay, that's promising to hear. Dr. Shikanda, I'll give you you have the privilege of having the last word in this discussion.
I would like to focus on behavioral change and also on health systems, the ones we have, because you find that most of our hospitals, in fact even the big ones, are nursing homes per se. So that when you go there, you find that you're supposed to come in with your doctor. So if your doctor is not there, no one is actually monitoring. And the people who are supposed to be monitoring, they have that mentality, that's not my patient, I'm not going to make any money from them. And if it continues that way, we'll continue losing a lot of our mothers. If I compare what happened to America with my current wife, the system was so robust that at 6 hours, they could change shifts. And the people who came in continued focusing. And they were so keen
there was no lag.
that nothing could have gone wrong. If anything goes wrong, they intervene immediately. Here, if you look at the systems we have in hospitals, and God forbid, if you take a patient to some hospitals, you'll find that before they get any attention, any medical attention, and they're in hospital, they waste a lot of time. And we lose them simply because they were not attended on time. So behavioral change and our systems in hospitals must change.
Must change. Thank you so much. I think you've summarized this very well for us, but clearly, again, a discussion won't finish today. But at least more people now know about the report and some of the issues around that as well. Thank you so much, Dr. Dan Shikanda, a consultant bereaved by maternal mortality, for sharing your story once again. We commend you for that. Thank you so much, Dr. Wangoi Muthigani, for joining us, Program Manager, Reproductive and Maternal Health Services, Ministry of Health, and of course, Joy Wanja-Muraya, a medical journalist. Each of you, I think, quite an eye-opening discussion, if I can use such an expression. Well, we take a quick break. You're watching Citizen Extra. Stay with us. We'll be right back.